All right, welcome to building your sports medicine practice. Quick show of hands. Who was at the interest group meeting yesterday? Bunch of people. Okay. Who is student? Resident? Other? Excellent. Bunch of sports medicine interested residents and students. Okay. My name is Jeff Feden. I'm at Brown University, where I practice emergency medicine and sports medicine. I'm going to give you a quick intro, and then we're going to introduce you to our panelists. So let's get started. No disclosures. The objective here, really simply stated, is to recognize various career paths available to the fellowship-trained emergency physician with a focus on academic practice. You're at SAEM, if you weren't aware. And so we're going to really try and focus this on academic practice. Of course, there are lots of different career paths and practice variations in sports medicine, but we're going to kind of focus it on academic practice and how our panelists have kind of crafted their niches and careers in sports medicine. Okay, so hopefully that's what you are here for. We're not going to talk about practice building in terms of RVUs and reimbursement and all those sorts of things. If you're interested, maybe we'll do that next year. So what is sports medicine? If you're not entirely familiar, treatment and prevention of injury and illness related to sports and exercise. It's not just athletes, it's taking care of active individuals. It's taking care of a senior in high school who's a Division I football recruit. It's taking care of, you know, your friend's grandmother who likes to get out and exercise and walk the neighborhood every day. So there's a whole range of patients that we see in sports medicine. It's not just athletes. And sports medicine is practiced in the office, in the training room, and on the sidelines on the field. Okay, so there's a lot of different practice settings outside of the emergency department, of course. A very brief history. The origins of sports medicine go way back to Herodotus, who was a 5th century BC Greek physician, tutor of Hippocrates, and he was really the first person that we're aware of that is credited with using therapeutic exercise for the treatment of disease and maintenance of health. And then really modern day sports medicine as we know it and as we practice it goes back probably to the 1950s or so, maybe a little bit before that, but the 1950s is when people like Dr. Houston, founder of the Houston Clinic in Georgia, started to kind of really do sports medicine, get out onto the sidelines. He's pictured here taking care of Auburn football players on the sidelines. So he's one of a handful of people who are really credited as founders of modern day sports medicine. And then you fast forward kind of through the 1970s when sports medicine really developed through orthopedics with the advent of arthroscopy and other things like that that made, surgery a lot less invasive and easier, particularly knee and shoulder surgery. 1991 is when primary care sports medicine came to be. And that was at the time when American Medical Society for Sports Medicine, and you'll hear me reference this in the talk, but the AMSSM was founded by a group of non-surgical primary care physicians from family medicine, internal medicine, pediatrics, PM&R, and emergency medicine got together, and they needed kind of a venue for non-surgical sports medicine to meet and discuss relevant issues as the field was beginning to grow in popularity among primary care physicians. And interestingly, sports medicine was one of the original EM subspecialties going way back to 1992. So it was one of the original subspecialties there. So it's been around for quite a while in emergency medicine, and here we are 26 years later, I think, if I do the math correctly. And so what is primary care sports medicine? It's what you see up here. It's non-operative orthopedic care. It's medical care of the athlete, taking care of medical issues in athletes, diabetic athletes, concussion, things of that nature. It's being a team physician and kind of coordinating the medical team for colleges, Olympics, professional teams, and incorporating the orthopedic surgeons all the way on down. And then there's mass participation medicine, where you see a lot of sports medicine physicians involved with marathons, half marathons, other events, but taking care of the runners, the athletes, rather than the kind of the event side, where you're taking care of the crowds, but this is the participants. Okay, so here's where we stand today in terms of the numbers. It's a relatively small subspecialty, which I think has its advantages and maybe disadvantages. But we have, as of January, through ABEM, 178 ABEM diplomats, so board-certified emergency physicians that are certified, have been certified at some point in time in sports medicine. Sports medicine is a certificate that you get. It's not a true board, but a certificate. So 178 people, and of the AMSSM, 5% of the membership are emergency physicians. So it's dominated heavily by family medicine, about 70% of the AMSSM membership, and so we're still a very small piece of the pie. How does fellowship training look in 2018? Kind of an overview, just where the fellowship programs are. The green pins there are where there are programs that accept emergency physicians in their applications. 150 or so programs, maybe a little bit higher than that. It's generally a one-year fellowship. There may be a couple of two-year programs that incorporate some research, but it's almost all one-year programs. And again, it's a certificate of added qualification. All right, so you get a certificate having completed an ACGME accredited fellowship. You get a certificate to practice sports medicine, and that's kind of recognized as the board equivalent. We're not going to talk much about fellowships. We have time for questions at the end, hopefully, and if you have some questions more about the fellowship process and training, we can discuss that a little bit more, but just to give you a brief indication, this is kind of how I classify the fellowship programs out there. They're the EM-friendly programs, which are either based out of departments of emergency medicine or have EM, the program director is an emergency physician. You have programs that have dedicated fellowship spots, right? And then you have some programs that have emergency physicians on the fellowship faculty that serve in the sports medicine fellowship faculty positions. And then you also just have some programs that don't have any of those things, but they've got a strong track record of taking emergency physicians and training them in their programs. And contrast that to the EM unfriendly fellowships, which maybe accept applications from emergency medicine residency graduates, but don't really have a great track record of training them. Haven't had many people come through their programs. And then you have some programs that just don't accept applications from emergency medicine residency graduates at all. And so in terms of careers, I said this yesterday at the meeting, and I'll say it again. If you talk to 10 different people that do emergency medicine and sports medicine or have that background, you'll probably get 10 different responses in terms of how they practice. So you'll see some themes, but you'll see really quite a variation how people do emergency medicine and or sports medicine. Of course, today we're going to really discuss more academic side of things, so academic emergency physicians, of which we are representatives. So we'll focus there. But you have other combined practice models where you may be working outside of academics, but in a multidisciplinary group where you can do some emergency medicine and sports medicine together. You may have some people that do sports medicine fellowship training, and they decide just to be emergency physicians. And maybe they do some team coverage, or they function in sports medicine in that kind of a role without doing outpatient practice. And then you have some people who leave emergency medicine altogether and can go on and have very successful careers in sports medicine. Okay, so I'm not here to tell you to think about leaving emergency medicine yet, but some people at some point in their career decide they want to change in venue, change in practice, and you can leave altogether emergency medicine. In fact, now you can leave your board certification behind as well in emergency medicine and just practice sports. All right. And there are team physicians that are emergency physicians in all of the professional sports leagues, at the NCAA, of course, and in Olympics. The chief medical officer for USA Soccer is an emergency physician. The chief of medical affairs for the NBA, the former, and I believe the incoming chief of medical affairs for the NBA is an emergency physician, and the medical director for the NFL Players Association is also an emergency physician. So there are a lot of us that are out there doing other things kind of in higher leadership and administrative roles. In professional sports and otherwise. So that's the quick intro. Our panel today consists of Dr. Waterbrook in the middle from University of Arizona, where she is also affiliated with University of Arizona Athletics and is an associate program director for both the residency program there and their fellowship program. So she's got some program director roles as well, in addition to her clinical practices. Moira Davenport is at Allegheny in Pittsburgh, Pennsylvania, where she is also an associate program director for the residency program there and works with Pittsburgh Pirates. And A.J. Monseau on your right, who is with West Virginia University and has also some affiliations and experience with USA Wrestling at the Olympic level. So, that being said, we're going to move into, for the majority of the session here, just a panel discussion. And hopefully we'll have some time for questions. We'll try and hold questions for the end and hopefully address some of your questions. Okay? Sound good? Excellent. Let's see. So we're going to start with a question to all of you, all right? And just in terms of clinical practice. So give us a quick, we did this yesterday, but give us a quick rundown, kind of the percentage and how you split your time in sports medicine and emergency medicine. Start wherever. Make sure you use the microphone. Perfect.
So at West Virginia University, I, at this point, practice 30% emergency medicine. That comes out to 4 to 5 shifts a month. I do 20% orthopedics, so I'm in the clinic 1 day a week, so 1 out of 5, 20%. And then my other 50% is actually with the Department of Intercollegiate Athletics, where I'm the head team physician and medical director.
Could you guys, is this on? Could you guys hear? So my split between emergency medicine and sports medicine is approximately 60% clinical emergency medicine, about 40% sports medicine, although it sort of flexes and changes over time. I work approximately 1 to 2 EM shifts per week. I also have a community orthopedics clinic that I do one full day a week, and then I also a couple half days during the month. I've started a musculoskeletal ultrasound injection clinic. Don't kill me, Jeff. Is it? Yeah, I don't feel like it's on.
There we go.
Can everybody? Oh, ha, much better. And then, as Jeff mentioned, I also work with the University of Arizona Athletics Department. I'm an assistant team physician, and I do event coverage sort of as on an as-needed basis, which is sort of as much or as little as I can put into my schedule during the year.
My schedule breakdown is pretty similar to Anna's. I'm about 2/3 emergency medicine, 1/3 orthopedics. So that, for me, that comes out to 2 ED shifts a week on average. And also, as an associate residency director, I usually end up going to all of our didactic sessions for emergency medicine. I do 1 day a week in the orthopedic clinic and then event coverage with the Pirates primarily, also with a local high school, and then also with USA Functional Fitness, which is the governing body for CrossFit.
Good. So, so that's kind of the split. Now, looking just at your clinical sports medicine time and your outpatient practices, I'll pose this to any of you. Give us a sense of, what types of patients you're seeing in a clinic day, and maybe where your referrals come from and some of those logistics.
I'll start that one. So I end up, initially when I first started the clinical aspect of sports medicine, I was seeing a little bit of everything, so a lot of concussions. Now we actually have a dedicated concussion clinic, for which I'm thankful, and I don't have to do shifts in that too often. And as I work with USA Functional Fitness, so I end up seeing a lot of CrossFitters, and then I'm a runner by my own background, so a lot of runners come to me. So now it's primarily all runners and CrossFitters, which is actually a fun population, to work with.
Yeah, so outside of the University of Arizona Athletics Department in the community clinic, we see sort of a mix of multiple different populations. We cover all of the local Tucson high schools, so we have a fair number of high school athletes that come in from anything from concussions. I probably see 2 to 3 concussions during one of my clinics per week, especially during the fall season of athletics. But we also see older folks with things like knee arthritis, and that's where we get a lot of a lot of injection practice. So pretty much we see all ages. They come from the community. They come from referrals from the emergency department, also the clinics at our institution.
So very similar, obviously, with our patients that we end up with. I would say that when I first went back to WVU from fellowship and we started our concussion clinic, I made a big push to all of the local emergency departments, as I knew many of them, to refer patients, especially the concussion patients, which at that time really had no home, and is that way at a lot of institutions, right? Nobody really wants them for the most part. The neurosurgeons don't want them. Neurology doesn't, unless you have somebody who's really interested, doesn't really want them. And so they would kind of fall through the cracks. So we really made a push to gather all of those patients, and by setting up that referral system, then it obviously has helped with the musculoskeletal referrals as well.
Okay, so moving outside of the clinic and into the team physician role, so you guys have all kind of achieved success, I think, in team physician roles ranging from, probably high school at some point, but now up into, NCAA athletics at power conference institutions, professional sports, Olympic sports. So we'll put this one to AJ to highlight his accomplishments. AJ was at the Olympics in Rio 2016 now with wrestling, so he's been an Olympic doc. And AJ, as he mentioned, last fall was promoted to the medical director and head team physician role at WVU. And so maybe you can just kind of give us an idea of how you were able to rise up into some pretty prominent positions in athletics, and how you got to those points.
So for Olympic level things, it really depends on your sport, and obviously you want to find something that you have an interest in, because much of my early travel with USA Wrestling was to some very remote places of the world that are not tourist attractions, and largely for these trips I would do nothing other than hang out at the gym for almost the entire trip. So it's not exactly fun unless you like the sport, and I did, so that's why I got into USA Wrestling. I started volunteering as a resident with tournaments around the U.S., and would just show up and help out with the medical staff. You know, I'd let them know I was coming. I wouldn't just show up. But so I'd help out with the medical staff, just volunteer and hang out and get to know people that way. And then got my name onto the medical pool, which is purely a sign-up application. But once you've done that a couple of times and they get to know you, then they start to say, okay, well, we have these 8 trips we're going to send a doc on. And once you've been on the list long enough, all right, we'll let that person go on one. And as long as you're not, you know, an asshole, then they like you. So we try to do that, and you know, be available and you know, be nice, and they ask you back. And so I grew that from 2008 or 9. I think it was my first volunteer, you know, kind of time with a tournament, and just over time, you know, kind of got to know a lot of the coaches and the team members and that type of thing, and eventually was asked to do the World Championships in 14, 15, and then the Olympics in 16. As far as the WU role, you know, first going back after fellowship, I you know, kind of volunteered and put myself out there to say, hey, to the head team doc, I'm willing to help you out however I can. And a few years went by, and eventually, you know, some additional help was needed a couple years ago, and then just as things happen, again, if you are available and you put yourself out there and you work well with other people, which I think in emergency medicine we all have a good knack for that, or at least hopefully you're honing that, because you know, in a team setting, as often as we work in a team setting with people who do not share our same training, right? It's easy, obviously, to work in a team setting many times if you have someone who's completely on your level of training and you're doing the same thing. That's not really applicable to most of our work situations, right? Because we're working with a team of people who typically have less training than us. And so being able to be a part of that team and you know, be respectful of their skills and at the same time, you know, not come off as an arrogant whatever. So, you know, I think we're good at that, and by showing that in a team setting with athletic trainers and possibly a physical therapist, or, you know, being able to talk to coaches and everything, that's where I think emergency medicine has a big advantage.
Any other thoughts if you guys have them, or?
No, I mean,
No.
I agree.
Okay, agreed.
Yeah.
All right. Well, so you know, it's interesting because I mean, you know, a lot of residents and students ask about pro sports and how do I be, you know, the team doc for the Pirates, right? And so the pro sports, Olympic sports have a lot of sex appeal. But does anybody want to just speak really quickly to the merits of working with high school athletes?
Sure. So I think you really need to work with high school athletes at some point in your career. I think we put all of our fellows at a high school, and when the fellow is there, he or she is the primary point person for the school, so you really get a feel of what it's like to be in the training room, what it's like to be on the sideline, what it's like to make those decisions and deal with the coaches. And I think that's an invaluable learning experience. So while it's not as glamorous or exciting as the professional level or the Olympic level, I think it's a key learning experience. And I think that it's actually fun sometimes to go. When I still work with a high school now, and it's actually nice to go back there because they, first of all, they keep you up on a different side of pop culture than the higher level athletes will keep you up on. But I think it's also nice just to get back to the grassroots level and to see people who are learning the sport, because you can pick up things too. I mean, I still cover high school football games. I still don't know all of the drills that high school football players do, but it's good to get back to that level and be able to just pick up some of the basics, because that just helps you in your further interactions. I think it's a key piece of your practice.
Yeah, and I would also just like to say, during my fellowship year, as a fellow, we would each get our own high school team, and that was actually one of the highlights of my fellowship year, because it was a place where I had autonomy. I developed my own relationship with the athletic trainer. They would call me when they needed things, and I was really, I would find my attending if I had a question, but really I was their point of contact, which is not really a role that you necessarily get, especially early on in your fellowship. So I thought it was super fun to be out there and sort of have my team. I also think that it's really important just from a community outreach perspective, especially some of the high schools, if they're underserved and they don't have physicians taking care of them. You know, there's lines of people who want to be head team docs at the collegiate and pro level. But at the high school level, it can be harder to find. And so I think, like I said, just from a community outreach perspective, it's really nice. They're super appreciative of you being there. And so you really feel like you make a difference.
So I think I'll address Jeff's undertone of that question, which is that for the highest level athletes, many times their reputation of being prima donnas is completely correct. So, right. So, and it's funny with the sports I've been involved with. Fortunately, USA Wrestling. These are guys that, for the large part, have no fame whatsoever, and they have a very short career. And although recently there's been some money put into wrestling, it is still very, very small. So the chances of that are very small. So they're very appreciative. They do not get care, on a regular basis. So when things are going on, they are really great people to work with. On the college level, right, you have some sports that are the haves and some that are the have-nots. And obviously some of the sports that are the haves can develop into that. And so that gets a little more difficult. Obviously on the professional level, I would say that you have some leagues where you can imagine that's the case also, but I would guess with Moira's experience with the Pirates, you get a lot of kind of low-level guys, especially at spring training, that are probably incredibly appreciative of your services. And then the final thing, obviously, is, as they've already said, then when you contrast that with the high school athletes or high school teams, especially those at underserved areas, the non-affluent high schools, these are kids that, right, some of their home situations will absolutely break your heart, as we're all, well familiar with from our work in the emergency department, that some of the home situations are so difficult. You can't imagine how a kid is even able to make it on a team and make it to every practice and that type of thing. So that's a really gratifying portion of the job.
Yes, the latter part of your answer spoke more to the undertone of my question. I mean, you guys have all been, again, successful at high levels of sports, but like you mentioned, there are people lined up to be pro, high-level college athletes, Olympic team docs, and there's a huge need for at the high school level. Right, there are so many high schools that are just that have no team position coverage, no sideline coverage. That it's an underserved population in sports medicine. So thank you for addressing that. All right, so let's switch gears just a little bit in terms of different kind of careers. Now, you have all also built different degrees of program leadership into your careers, both at the residency and/or fellowship level. And so we'll put this one to Moira as an associate program director in the residency program at Allegheny and an educator. How do you see the role of the fellowship-trained emergency physician in kind of bringing expertise and educating, EM residents on sports medicine issues, and even off-service residents, and maybe going down to medical students?
So I think this is actually a great way to use your sports medicine training. For those in the audience, how many of you actually had a good orthopedics curriculum as part of your intro to clinical medicine? And I think that's fairly common from medical students and residents all over the country, and I think that this is a niche that we can easily fill. I do spend a lot of time when our interns come in. We have a whole introductory month, and a whole 5 days of that is actually dedicated to the musculoskeletal exam. We incorporate ultrasound, image review, that kind of thing, but it's actually a lot of fun to teach them, and they're actually really appreciative because a lot of them come in and say, okay, I did a month of EKGs, I did a month of anesthesia, I have no idea how to examine a knee. And they just kind of look at you with this blank look and think, like, wait, I can read, I know how to fix an LVAD patient when the LVAD pressure is off, but I can't examine a shoulder. So I think it's a great way for us to incorporate our skills into emergency medicine practice. Along similar lines, when we're actually in the emergency department, I think sports medicine training comes in very handy. I think I'm much more comfortable doing more reductions than both of fractures and dislocations than some of my colleagues are. And I think it's a nice way to teach the residents and to really incorporate another skill that if you do go into community emergency medicine, that will come in handy as well. Also, just the last thing is that, two more things actually. If you are thinking about research, it's a nice little realm to have. Musculoskeletal ultrasound is a huge world that's open for research. And then when it comes time to give your academic lectures, I'd much rather do a lecture on the latest updates in sports medicine rather than the newest components of the DSM-5 or 6 or whatever they're on now. So it makes it easy to prepare lectures as well.
Any other comments? If not,
I agree.
You agree. All right, we'll give you this one. So we're going to go just straight off topic just a tiny bit, because I said we weren't going to talk much about the fellowship process and that whole thing. But Anna is an associate program director in the Sports Medicine Fellowship program at Arizona. And so given the audience, I thought you guys would be interested to hear from an APD, what makes an applicant competitive for fellowship.
So I think number one, and sometimes if people are super gung-ho about getting into a fellowship program, they can sometimes forget this. I think number one, especially during residency, your job is to be a really good emergency medicine physician. You get 3, maybe 4 years at a few programs to learn everything you need to know about emergency medicine. So focusing on being a good doctor is priority number one. But I think, things that you can do during your residency to align yourself with getting into a sports medicine fellowship. I mean, you've got to do a resident research project so you can align it with sports medicine, especially if you have a faculty member there who can help mentor you on it. I mean, you've got to do it anyway. And truthfully, even if you don't end up going into a sports medicine fellowship, you've still completed your requirements for residency. So I think trying to align some sort of a research project with sports medicine is great. Definitely getting some time rotating with a sports medicine physician in a clinic setting. I think that's important really for 2 reasons. Number one of the things we look for in applications is that you have a letter of recommendation from a sports physician. But I also think that it's important for you as an applicant to sort of get an idea of, is this something that I really want to do? Is this the right fit for me? Because sometimes sort of your idea of what something is like is not actually what it's like. Certainly getting involved in some event coverage is great. I think even if you're in a place that doesn't have a team physician that you can go and shadow, another way to get involved is to do event medicine. Most places have like a local marathon or even 10Ks or 5Ks, or they're always looking for volunteers. So that's sort of a low-hanging fruit if you just want to go out and volunteer. And then, like I said, I think being teachable, being humble, being a team player is super important in the practice of medicine, but especially in sports medicine. As some of us have talked about, you're working with, not just other physicians, but you're working with coaches, you're working with athletic trainers, you're working with athletes. And so being a team player and being professional is super important in the sports medicine world. And so I think that honing those skills even during residency is important. One thing that also comes up, I get asked a lot is, what should I read? How can I hone up on my musculoskeletal physical exam skills, et cetera? And while I think that that is important, especially if that's an interest of yours, I feel like, we've got a year. We can teach you that stuff. I think that it's more important to get some of the other things in place. And, during the year that you're doing your sports medicine fellowship, that's really where you'll really hone those skills.
Good.
I guess I would say, for emergency medicine, you guys are really smart. So when you come out of residency and you see an application, right? So against many other candidates from other specialties, you will have very competitive applications just off the numbers alone, which we don't like to just go on numbers, but they do get looked at. So the other thing is the idea of a rotation, right, is good. And I mentioned this yesterday at the interest group, is that, I've advised a couple of our residents who have gone on to do this, is one step further than just a month rotation is to find a couple of times to come back to the clinic, even if it's, 2 or 3 times after your rotation at kind of 6-week intervals, which is a common follow-up time period, so that you can try to have some continuity with a few patients to then be able to say on your application that you've done that. Not only did you do a rotation, but you went the extra mile to go back a couple of times later to get some follow-up with those patients, which when a family med program director is reviewing your application as an emergency medicine resident, that's going to be one thing that they're already thinking off the top, is that this person is emergency medicine, they don't have any follow-up time, no continuity with patients. So if you show right there that you took the time and the energy to arrange that, that'll go a long way.
Great, thank you. So I just want to step outside the clinical realm for a minute, just so you know that there's kind of life in sports medicine in other areas outside of clinical medicine. All of you guys have been involved in national organizations as well, in leadership positions, ACEP, SAEM, AMSSM. So we'll put this one to Anna as well. She's been very involved with AMSSM. Which we alluded to earlier. And so And if you would just let us know maybe some of your projects, some of your roles that you've done kind of at the national organization level, kind of outside of emergency medicine, outside of ACEP and SAEM, and just maybe the professional importance of that to you and your career, and also maybe the professional importance to the subspecialty and how you have represented us very well outside of emergency medicine.
Well, I think, one thing that's really nice about the niche of an emergency sports medicine physician is that we're really a very sort of small, tight-knit group. And with there not being a lot of us out there, it's a lot easier, I think, than some other fields to build your academic career. In emergency medicine, there's not very many sports medicine providers. I think you said that there's 178 now EM sports medicine boarded physicians, which is amazing because last time I had looked at the numbers, it was 150, and 28 more might not seem like a lot, but it's actually pretty significant. In general, actually, in emergency medicine, not that statistically, if you compare it to fields like internal medicine, not that many of us actually pursue fellowship training. So 178 is actually on par with a lot of other subspecialty fields in emergency medicine. Anyway, so you kind of get to be an expert in both fields. So in the emergency department, there's not many people who practice sports medicine, so you're almost sort of, you're by default the expert in sports medicine, and you bring a new perspective and a new area of knowledge to the emergency department. But I'd say the same is true in the sports medicine world. We make up a very small portion of the sports medicine community. It's dominated mostly by family medicine practitioners. And so we have a very unique skill set that's very much needed in sports medicine, especially when you think about things like sideline management and the emergent management of injuries. And we really bring a unique perspective. So it's really cool and really great because you get to be involved nationally at many different levels, whether you're doing it from the emergency medicine or the sports medicine side. To answer Jeff's question, though, so just so you guys know, so obviously there's SAEM, and I know a lot of you guys, by show of hands, were at this sports medicine interest group yesterday. There's a similar thing through ACEP. There's a sports medicine interest group. But then through AMSSM, which is American Medical Society for Sports Medicine, that's sort of the large non-operative or primary care sports medicine group. And the largest proportion of those folks are family medicine providers, but it also includes emergency medicine, it includes pediatrics, internal medicine, and PM&R. And it's where sort of where all the primary specialties come together in the practice of sports medicine. And so being involved in that community is really great because because I think that we as emergency physicians play a really vital role in the sports medicine community, and so it's important to have our voices heard. I mean, I've been involved, I basically started volunteering for various committees. I would show up at the EM Sports Medicine Interest Group, and it sort of just evolved from there. I've been on a couple of the program planning committees and have taken some leadership roles coming up on the program planning committees. And I think, if one thing that you'll hear on this panel, I think that, if you're a hard worker, you show interest, you're smart, and you show up for things, it's amazing the opportunities that you'll be able to get.
Good. So we have probably about 5 minutes, and next I want to save about 10 minutes for questions at the end. So just to kind of wrap things up, I'll pose this to all of you, if you would each just kind of discuss maybe a challenge that you've encountered or overcome in building your career, kind of developing and creating your niche. It's not all glamorous, I would like to think so, but maybe just kind of a particular challenge that you've encountered in building your career.
Well, I think one of the things that I've encountered that in some ways I feel like ultimately has become an advantage. I think scheduling can be hard, right? You're juggling trying to work EM shifts, which can be at all hours, different times of the week, et cetera, with a clinical practice. I think it's definitely easier in the academic setting than in the community setting, although it's definitely done in the community setting in multiple different ways. It's nice if you can be hired by one entity so that everybody knows what you're doing. But I feel like even with my different roles, not everybody always knows what I'm doing. I can't be at a residency function because I'm at a fellowship function and vice versa. And so you sort of wear many hats. But I also find it super fun, and my joke is that I love the emergency department 8 shifts a month. But outside of that, I can get kind of burnt out in the emergency department. But I also feel that way about the clinic. I don't really want to be in a clinical setting Monday through Friday, 8 to 5. I feel like that would drive me nuts too. And so I feel like the diversity in my clinical practice is really great. You know, there are some challenges in terms of scheduling. You know, it definitely takes me out of the mix for some prime EM shifts during the week. And so I'll, you know, but I've been able to work my shifts around my clinical practice. And I also feel like it's nice because Wednesdays when I'm involved in the residency and Thursdays when I'm doing my sports medicine stuff, I almost feel like a normal person. I sort of have those banker hours, and I know that those are sort of reliable days that I can schedule things during. And then, you know, one of the things that I like about my EM shifts the rest of the days during the week is that I'm able to, even if I have a shift, it could be, for example, in the afternoon, and I can do normal people things like, you know, go to the doctors or, you know, take my car to emissions, or, you know, you can get other things done during the week. So sort of a blessing and a curse at the same time.
AJ, Moira?
So biggest challenge. So, yeah, I think, you know, just number one, so right off the top, when I first wanted to go into sports med, no one from our program had gone into it from our residency. I had an idea how I wanted to do it. I had been thinking of trying to do it since I was a first-year medical student, and I figured out that you could do EM and sports together. So I had planned some stuff through that and arranged things kind of on my own, but it was kind of a choose-your-own-adventure thing because nobody had done it before, so I was just kind of making stuff up. The application process was interesting. The resources that we have now through multiple websites, EMRA, ASEP, others, are much better now than what they were then. So it was kind of like shooting in the dark a little bit. And I guess one thing is this, as Anna kind of alluded to, is that people still kind of look at you like, you do what? You went into emergency medicine, you want to be in a clinic? Like, that doesn't seem to fit with our personality, right? Everyone's like, I'm too ADHD to be in a clinic. Well, if you think about it, we have like ADHD to the max, right? Because we get to be, like Anna said, like if I was in clinic every day, I would get so bored. And if I was in the emergency department every day, I would probably get burned out. Because I kind of go at things hard. But this is an easy way to give yourself nice career options and be flexible and be able to get into some other interesting things.
I agree with what Anna and AJ have said, and I think one of the harder things in setting up a model like this is there's no precedent. So the great thing about sports medicine is that you can do with it what you like, but it also can be hard to do with it what you like, because trying to get joint appointment in orthopedics and emergency medicine when nobody has done that before, it takes a little bit of time. Not so much from the emergency medicine perspective, because I think most academic chairs are very well aware of what we can do. It's more on the orthopedic side if they don't have a non-operative person. Or convincing, I know another issue along similar lines is convincing orthopedics says, oh wait, we actually can use the ultrasound machine. If you buy us one for the clinic, we can actually do a lot more injections, we can do a lot more diagnostics. And they're not looking at it from a patient care perspective, they're looking at it from a billing perspective. So I think the administrative aspects from that perspective, that aspect rather, can be challenging, but I think it's worth it in the end.
Great, thank you. And so we're going to finish on a high note. To finish up, so I want each of you to tell me in just a few words what's the most rewarding thing about the work you do or the career you've built. Oh, come on, you don't have to think that hard about it, do you?
I actually, as I mentioned before, I'm a runner, and I love going to our local road race in Pittsburgh and have somebody come up to me and say, oh, Dr. Davenport, thank you so much for getting me back out here. And the first time it happened, I was kind of shocked, because it's that moment of, you're seeing somebody in a different setting than you're used to seeing them, and then you realize that, wait, like, they actually recognize me with my hair in a ponytail and running shoes on, and they're actually thankful that I'm getting them back out here, and that's actually been a great bonus for me.
Yeah, I think that sports medicine has really given me a little bit of follow-up with my patients, which we really don't get in the emergency department, but it's still sort of focused and closed-ended. And I remember, for example, when I had gone out on maternity leave, I came back and one of my patients had made me a blanket, and there's just not something you get in the emergency department. That being said, it's focused follow-up, so you still don't have to necessarily go through their whole list of chronic medical problems. So I find it very rewarding because you do get some sort of that follow-up care. I also really like working in the training room for sort of that same reason. It's like you get to work in the community, and you don't just see the athletes when they're sick. You also get to see them when they're well and they're, performing at their best. And so you have a little bit more background when you do take care of them and they end up seeing you in the clinic. And so I think that just really adds a nice piece to our clinical practice.
Take us home, AJ.
So emergency medicine, all right, is amazing training for sports. We've already said that multiple times. My first large trip that I went on with USA Wrestling, we went to Siberia for 2 weeks in January, which is just as beautiful as you would think. And at the second tournament there, one of our heavyweights got headbutted and split, not the typical kind of, transverse laceration, but an actual vertical laceration and a bit of a stellate formation, and he split pretty much down to bone. And this was in the semifinals of this tournament. He had, in the process of injuring himself, had won the match, actually. So now we had about an hour and a half or so before the next match was going to happen in the finals, and for that tournament there was a preem for the champion, but not for the runner-up. So these guys make almost no money. He wanted to get that preem, and so in the back room of this awful gym in Ulan-Ude, which is about an hour's drive from Mongolia in kind of eastern Siberia, we laid him on the floor of the locker room and sewed up this vertical laceration. And it took a couple of subcutaneous stitches, several vertical mattress sutures to, again, be able to allow him to wrestle with what I thought would be a strong enough hold. I mean, not just have it rip right back open as soon as he got out there. The tournament physician watched me do it and sat there with me. He spoke no English, but through the translator told us that he was quite impressed with all of my medical supplies that effectively I had been able to smuggle into his country, and which is a whole other story to begin with. But that was, and he went out and won. So it was, to me, like that was just one example of a really gratifying way that some other docs, non-EM people who aren't familiar with suture repair quite that well may not have been able to do that in an adequate fashion to let him go and compete at that high of a level. So just having that training that you all will end up with can really pay off in a sports med career.
Yeah, I agree. And sharing in the successes of your athletes is like tremendous feeling as well, obviously. So thank you to our panelists. Thanks to you guys for being here. Hopefully many of you are the future of sports medicine sitting up here 10 years from now. We still have a few minutes, so let me just, I have one more last slide. If you want our contact information, feel free to get in touch with us. It gives you some resources as well. And we have some time that we'd be happy to take questions if you have them. Anybody? Yes, I'm going to have you use the microphone if you wouldn't mind.
I know you had mentioned one of the questions you get asked as an emergency medicine physician or resident applying for fellowship is about continuity of care. Are there any other specific emergency medicine applicant questions that we should be prepared for?
I don't think so. I think that for an emergency medicine resident, that's probably the one, I would say, thing that, at least from the family medicine perspective, they might be a little bit hesitant about. You've never been in a clinic. Are you going to be able to do some of the continuity of care things? But I think other than that, it's mostly the typical fellowship questions.
So maybe team coverage along with that, because a lot of programs don't have that set up, as we said. So trying to find somebody at your institution, whether it's a family med person, whoever it is, say, hey, I want to do this. Can I come show up with you at the high school football game the Friday nights that I have free? Because we know your schedule may not allow it every week, so you can't be the person like some of the family med residents can arrange to be the person at a place. But you can at least show the initiative to show up when you can.
I would say in general, actually, emergency medicine residents are sort of known for being smart, hardworking, for doing a good job, and you are in general sought after as applicants. So, as long as you get as long as you line up your other ducks in a row, you really are very, in general, good applicants for sports medicine fellowships. We tend to score higher on the in-training exams as well. A necessary evil of medical training, as you all know.
Any other questions? Good. Well, feel free again to get in touch with us if you have additional questions afterward, or you'd like us to direct you to any of the resources which are scattered about, different websites and organizations to help you in your career path, make your decisions and whatnot. So thanks again for coming. Appreciate it.